when it's cancer or it's a heart attack or it's paralysis or incredible pain, the system has to be put together to just work for you, because in those moments you're not a consumer, you're a loved one, you're a patient. And so I just believe that healthcare doesn't set up to be a great consumer industry.
My money.
I get money from you.
Money in the bank.
Young money.
It's a rich man's world.
I have been in the health insurance industry for over 30 years now. And for the last 22 of that, I have been in a company called Holmes Murphy. And what we do at Holmes Murphy is we work with employers to help them navigate the insurance space. The side of it for me is really the health insurance side of that. And if you ask what's a Holmes Murphy, we're an employee-owned company with about 1,000 employees that serves employers and tries to make this whole thing work better and cost less.
That's good. You're still independent. Some private equity firm isn't saying, we want to buy you guys yet, huh?
I sometimes say we're very private equity.
Okay.
It's our own, if we spend money, we're the ones writing the check. And, I kind of love that. I love the entrepreneurial kind of way of that, and having a group of people to, we're in the fight together to try to make it work better.
Great. So, as I said, before we get on here, I used to do this. There's a lot of health and welfare plans. I used to do a lot of self-funded plans, the self-funded HMOs and all that stuff. But why did you write this book, The Voter's Guide to Healthcare, Den? Why would you write a book like this? It's a monumental task. So why did you do this?
Yeah, we all make mistakes in life. So, but it really, I truly am passionate about trying to help solve these problems. And quite frankly, healthcare is a massive problem. And being in the mix of it, we actually have a clinical company that I co-founded also. So, we, in some of our business, we work with hospitals and physician groups. In some of our businesses, we work with insurance companies. And then in most of our business, we work with employers. So we see how the money flows in healthcare, and most just can't get their head around and understand, well, how does the money flow? And if we don't understand how the money flows, it's really hard to fix it. And in the end, the farther away from that money flow you are, the less voice you have and less chance of getting it successful you have. If you're a patient, you have no chance. A patient cannot financially win. So we've got to rework how the money flows so that patients have a chance for this system to work for them.
Yeah, because we shop for everything. I mean, we can buy cars online. We can, during this whole pandemic, we can buy anything. We can buy groceries, everything online now. But when it comes to healthcare, it's really kind of it's a different beast. I mean, when you're sick or whatever, you want to go to a great doctor, whatever, or the best. But people don't shop for healthcare at all, do they?
They don't, and in fact, I don't believe that they can. Which, for what I do for a living, probably sounds odd to say that. So I sometimes tell the story of our family dog Max. Max was a spotted dachshund that we gave to my daughter at Christmas once year, and she was probably, let's say, she was probably 8 years old when we gave her Max. And so one day I came home and Max the dachshund was in a chair. He liked furniture, but he couldn't move. And figured out that Max the dachshund was paralyzed in the chair. And Max was about 10 at this point, and my daughter's crying, something's wrong with Max. I figured out he can't move. I scoop Max up. I take him to the emergency vet on a Saturday, and they say, well, we think, dachshunds have bad backs, and we think Max may have slipped a disc and it's compressing, and that's probably what it is. But to figure this out, you got to do an MRI. Well, it's my daughter's dog.
It's our children, yeah. Okay.
It's Saturday. Max is getting an MRI. So immediately swoop Max in, get the MRI. They show me, they say it's right here. He slipped a disc. It's compressing his spine. If we do emergency surgery, we can relieve that pressure, and there's high likelihood that Max will be able to walk again. Well, okay, so within 2 hours of Max the dachshund being found paralyzed in the chair, not only had he had an MRI, he was in back surgery, and this was Saturday. So was I a consumer in this? No, I was a dad.
Your father,
and it was my daughter's dog, and she's 16 years old, and the last thing in the world I was going to do, if I had the money to try to do it, I was going to try to save Max the dachshund. And so that's for a dog. If that's your daughter or your spouse or your parent or a friend even, and you say, wait, if we tried this, I think we could relieve the pain. They could walk again. They could live. When it's those situations, you're not a consumer. You're a patient or you're a loved one trying to figure out how to get this better. And I don't believe that in those situations you make consumer decisions. I think you make life decisions. And so because of that, I don't think healthcare in total sets up to be a great consumer industry. It is if you're looking at the basics and small stuff. Do I get it over here? Do I get it over there? Yes, some consumerism can help. But when it's cancer or it's a heart attack or it's paralysis or incredible pain, the system has to be put together to just work for you, because in those moments you're not a consumer. You're a loved one. You're a patient. And so I just believe that healthcare doesn't set up to be a great consumer industry.
And which leads me to kind of a next question. By the way, it's a great book, and I have my copy here. Let's see if we can see the healthcare. Okay, is there a solution? Okay, within reach. The government really screws around with the rating systems. Okay, so this is the whole thing. It's like, because I'm an old group guy. Okay, and I used to do a lot of stop reinsurance and things like that. So I know the drill. And I'm saying, as like all this, the Affordable Care Act and all this stuff, it's the government is kind of like thrown out, they've thrown out the rule book of actuarial science. I mean, when it comes to healthcare development, you and I, that a female lives longer, but the females conversely will have more medical care within the younger ages and so forth. We know this, because you've spent 30 years in the business, I spent a good chunk. We know this is the cost, but the government kind of throws out the rule books, the mathematical equations behind this stuff. Am I making sense, Dan?
Absolutely. Now, for your listeners, here's kind of how. So, insurance is based on the concept of underwriting.
Yes.
So, started in Europe with ships coming to the Americas, and people would write their name under the cargo, and so that concept of underwriting is where it started. And we actually had another industry, the mortgage industry. If you remember back about 20 years ago. They decided that underwriting was a bad idea. Everybody should be able to get a house. And so the government changed the rules, said banks can't really underwrite. You got to loan this. The government will be the backstop. And when that all blew up, we had a mortgage crisis that almost crashed our entire economy. Because the government changed the rules of underwriting, of just actuarial science in the mortgage industry. They've done the same thing in healthcare.
Yeah.
They said, okay, well, we don't like that answer. So I get that the answer is this. I don't like that answer. So we're going to say the answer is this and write it into law. So I could write into law that 2 + 2 = 5 and tell everybody in America it's 5. And you can't say it's 4 because by law I've said it's 5. The reality is it's still 4, even if the government said. And so that's kind of how the math works when the government gets involved, is they don't like the answer. So as an example, analysis of claims would say that, the risk for a male between 60 and 64 years old is about 7 times the risk for a male between 20 and 25 years old.
Yeah.
And that's math.
That's math.
But that feels like it's discrimination against older folks than that. The math also says that, women who are between 25 and 35 spend more in health claims than men between 25 and 35. That's math. But politically, you can take that and say that's insurance companies discriminating against old people and discriminating against women. And I'm almost in that grouping. It just so I understand the math, and I understand why you could convince people they're victims of some kind of grand scheme where everybody's out to get you. So the politicians have kind of done that, unfortunately. But the math doesn't work.
Yeah, but that's the whole thing, because I remember when I used to do a lot of group, but small group. I remember I live in the state of New Hampshire, and this is back, was done about 20 years ago when they had small group reform, groups up to 100 lives. Well, 95% of the businesses in the state of New Hampshire are under 100 employees, and they said we can't do any experience rating up to 100 lives. So all the insurance companies said, we're out of here, you follow me? And so what I'm saying is that we know it should be some scientific thing. They've thrown the rule books out the window in favor of politics. And so, but also this is one of the things that I've read too in your book is if you look at the statistics, then we spend more than anyone on healthcare in the civilized world. Am I correct?
Absolutely.
Okay.
Both on a per person and percentage of GDP.
But we have one of the worst mortality rates in the world. Is there a correlation to follow me, or is it?
Yeah, there is, and so that I'm a Texas public school educated person. So there was this study that came out from the Commonwealth Fund, and it was called Mortality Amenable to Healthcare. And I know what all those words mean, but to put them together, I'm not sure what they're talking about. What they studied was how frequently do people die from something that could have been found and cured within the healthcare system. In other words, the care was available, the drug was there, the procedure was there, something was there, they could have found it, treated it, you might have had to deal with it for the rest of your life, but you weren't going to die.
Yeah.
How frequently are people dying from things that could have been cured? And in the United States, what this study found is that people die at a 58% faster rate than other economically developed countries from things that we could have cured. So the care is available, we spend more, but because the cost to the patient is so high, people don't get what they're, because they're afraid, I can't afford it, what's it going to be? Or they don't have a primary care physician and they don't know where to go or how to get it, so they just delay treatment. All of those small decisions end up with the harsh reality that Americans are dying from things that we could have solved just because they couldn't get there. In the book, I call it the T-Rex effect. And what I mean by that, if you think about a T-Rex, the defining physical characteristic of a T-Rex is their little T-Rex arms, right? Their arms can't go over their heads. So if you had a button up on the wall and the T-Rex, if they could just press that button, they could live. They could get cured and live. But because they got little T-Rex arms, they can't reach it and they just die, even though the care was right there. You go, it's tragic. I mean, all they had to do is hit the button. It was right there. You go, yeah, but they couldn't. And unfortunately, with healthcare in America, the way we're doing it today, care is available. The button's on the wall, and we've put it just out of reach, and people are dying. Hundreds of thousands of people. And these aren't, it's not one of those things you say, oh, well, this is all the poor population, and that's what it is. Or it is, there's some kind of racial issue to that, and it's that. No, it's widespread, and many of these people are in the poor population. Many of them are in disadvantaged populations, by the way. Many of them are quite simply middle-class working people who don't know how to use the system their employer gives them, or the deductible's too high. I mean, so it is widespread and a problem, and we really need to solve that. I wish, maybe be my hope for politicians, in running for president, instead of slinging mud on the other side and talking about how terrible it is.
Yeah, I agree.
They would actually talk about this issue and say, you know what? And here's my plan. Here's how I'm going to make it more predictable, more affordable, get more people to primary care, And we can actually, within 5 years, move from the worst to medium, and in 10 years, move to the best when we look at how effective our system is. Now we're talking. But unfortunately, our political campaigns don't really work that way today. But they need to. That would be what we need to be doing.
Yeah, that would be honest with you. It's disgusting. There seems to be no compromise anymore when it comes to healthcare debt. I mean, it's just they're all this slinging mud, and it's like don't we agree on certain things? Everyone has a right or at least an access to good healthcare, reasonable healthcare at a reasonable cost, and there has to be a cost to it. Okay, you can't get something for nothing, but I'm just tired. Oh, we Medicare for all, no Medicare. I mean, there's got to be some. There's no compromise. Am I correct? I mean, I think
the easy campaign sign is to hold up a sign that says "Healthcare is a right."
Yeah.
Okay, but you cannot have a right without a corresponding responsibility. And so, if it is a right, then what is the responsibility that goes along with that right? If we could just hold up both those campaign signs, now we're talking. That I do believe there's a pathway where every American could have health insurance. It's not that far out of reach, but it means we have to take some personal responsibility. That we need to pay our share. And it means we need to provide programs for people who can't afford it. Nobody, if anybody's got a heart, they want to see people get the care that they really need. I'll give you an example. If you take the uninsured population in the country right now, you take about 20% of that. Those are undocumented folks. And in the book, I say, this is a book on healthcare reform, not immigration reform.
Yeah,
so I'm not touching that.
Good for you.
How we deal with that issue is separate from healthcare. So if I leave that population aside and say that one's a separate issue, figure that one out. But if you take the population that is uninsured, got about 25% of the total, including the undocumented. So you leave that out. Let's say a third of the population that doesn't have health insurance in the United States today is eligible for free health insurance through Medicaid. They just don't take it. A third. So we could eliminate that challenge for a third of the people. But what it would mean is if somebody showed up at a doctor's office or a hospital, was eligible for Medicaid but didn't take it, they just said, nope, I'm just you give me the care and I'm gonna move on. That doctor or hospital would have to say, we are not going to treat you until you sign up, because the only way that we can really provide effective treatment is if we get you in an organized system of care, and we can get paid through Medicaid to provide the care, or we're going to have to find a way to charge everybody else more because you can't pay your bill. And so in my Texas tough love, I would tell that person who's eligible for free coverage that unless you take the free coverage and get in the organized system of care, I'm sorry, you get no treatment. Why should a doctor or hospital have to provide care where they know they cannot get reimbursed, where they know the person can't then get referred to other treatments for the follow-ups and this? They're going to be coming back because they can't get paid for any of the other services that they're going to need, or they can't get the prescription drugs. You get them in an organized system of care, they could treat them, stabilize the situation, get them a referral for ongoing care, get them prescription drugs so that they deal with that, and all of a sudden that person doesn't have to show up at the emergency room 2 weeks later. But in today's world, the hospital can't tell that person no, and they know they're going to see them again and again for the same thing. And eventually that person is going to pass away because they can't get the care they need because they're not in an organized system of care. We have an organized system of care, but if we don't have accountability, we can't say you have to take it. And so this political discussion, it's missing the element of accountability, because we need a heart around healthcare. How do we take care of people?
Sure do.
But we also need a head. Let's stop being stupid. And so if we think about how to get people connected in an organized system of care, hold everyone accountable, because it's a right and it's a responsibility, then we can actually solve our problems. But if we just want to say it's a right, but hold no one
Yeah.
accountable, then we're never going to make progress.
Yeah, it doesn't work. You have to have accountability, and one of the things too, Dan. I mean, I don't know if there's any correlation to this. Does it, that, and I've been out of the line of business you've been for a number of years, but is there any renewed focus on wellness or that type of thing? Because as you know, I know COVID's big in the whole thing, but guys, by the way, 70,000 people a year have been dying for opioid abuses, and I live in New England. I live in New Hampshire, one of the worst states in the country. Okay, and people do drugs and fentanyl. We know that they're gonna die, whatever. But has there been any renewed focus, and is there any correlation between wellness and lower health care costs today?
I will answer that as in the odd, both yes and no.
Okay.
So traditional wellness that says, we're going to, count your steps and we're going to do this and do that. There is no economic benefit. However, if someone says what I refer to as a disease-specific battle plan, they say, okay, we're not going to do traditional wellness, because who you really get in that are the healthy people. That's who it is. And so, okay, so we're gonna pay the person who runs a marathon every year to go run. That person's gonna run anyway. But the person who's 350 pounds and has diabetes and cardiovascular disease, we're gonna charge them more for health insurance because they don't run. That doesn't really work. It doesn't in the end, it doesn't get the right incentives. But if an employer or an insurance company says, I am going to have what I would call a disease-specific battle plan, and by that say, okay, I hate cancer. My mom's a 3-time cancer survivor. I hate cancer. And so if we said, we're going to go kick cancer's butt, then how are we going to do that? Well, we need to make sure that we know how many people are utilizing tobacco, and can we do something to help people stop doing that? Because we realize that cancer likes that. We don't like that because of what it does. I don't hate the person who smokes.
No.
I hate what smoking does to the person.
I agree.
Okay, so we can do that. And we said, well, what about mammograms, and what about pap smears, and what about PSA exams for men of appropriate age? What about age-appropriate cancer screenings? And you're right. We think that we believe in our insurance that everyone should have an age-appropriate cancer screening. So we're going to give you a free paid time off day when you get your age-appropriate cancer screening. You get your colonoscopy. And we're going to start measuring how compliant are we with age-appropriate cancer screenings. And then for people who get diagnosed with cancer, we're going to make sure, if you want it, you've got access to the best cancer specialists in the world, because they're in the United States. If you want to go, in your local area, you can do that. But if you want access to somebody else to talk to, the best specialists in the country, here's a way to access them. If you call wellness doing those kinds of things, it absolutely works. But you have to get specific. You have to say, here's our plan around heart disease. Here's our plan around cancer. Here's our plan around musculoskeletal pain. And if you start thinking about, but how do we win the war against these diseases and these conditions? Wellness comes to life and can work great. Unfortunately, far too many employers don't get that level of understanding, and it comes off as if the person who's in the program is the problem, and the person's not the problem. The disease is the problem, and I refer to it as a wellness scavenger hunt. And I didn't like scavenger hunts as a little kid, and I don't really like them as an adult. So if you give me a list, here's all of the boxes I got to check. This is my scavenger hunt list, and if I check all those boxes, I get $50 a month, off my health insurance. Well, that's a scavenger hunt, not a real wellness program in my mind. And I don't believe that the scavenger hunts have an economic benefit, but I do believe that targeted programs around very specific steps to help people win the war against disease, I think are phenomenal. I use pre-diabetes as an example. Depends on whose estimate you use. We've probably got between 25 and 30% of the adults in the United States have pre-diabetes. And pre-diabetes.
And so from obesity, a lot of that's it's really a lot of it.
There's a connection between obesity, but there are actually a lot of people who are not obese that are pre-diabetic because so we want to say that's a fat person's disease. It's not.
No.
And that there is a link, but we can't look at somebody and say, oh, they got a problem. They may be heavy, but they may be healthy. Somebody else may be skinny but not healthy. So we can't just look at people and say we've got it nailed. But we can look at their blood. One drop of blood tells us everything, and blood doesn't lie. So pre-diabetes is a situation where the body is losing its ability to process energy, but you aren't yet diabetic. So I call it the diabetes escalator. And so if you're in a department store and you get on an escalator, what do you have to do once you're on that escalator to get to the next floor? And the answer is nothing. I'm on the escalator. If I do nothing, it just carries me right to the next floor. That's pre-diabetes. So we've got about 25 to 30% of adults in this country that are on the pre-diabetes or on the diabetes escalator. If they don't do anything, they are going to end up with diabetes because their bodies are starting to break down. If we can identify those folks, help them with a little lifestyle, a little education, a little lifestyle change, that can reverse. The body heals itself and that person never gets diabetes. They never have all those complications, but we don't talk about it in wellness. So we really shouldn't talk about all this other stuff. We should be talking about cancer and diabetes and heart disease. And if we got specific, man, we could do great. But when we don't get specific, we have people walking around that are on the diabetes escalator. They're just about to get diabetes and they have no earthly idea because they feel fine.
Now, I'm going to kind of make you. Let's say you were kind of the czar of healthcare, Den. Okay, and say you get involved, and it doesn't. Who cares who's elected? But they say Den Bishop's the head of healthcare. Okay, for the U.S. What would be the most important things you'd implement?
A couple of things. I would have a couple of priorities. My first priority would be to lower cost for everybody. That would be my first one. Cost too much. And to give you a sense for that, the total cost of health insurance last year for a family of four, including what the employer pays,
it's ridiculous. So what is it?
over $28,000.
Who can afford that?
Okay, so we got to deal with cost. My second thing is we got to deal with access, because everybody could have insurance, but we put all the hospitals and doctors out of business, and then well, what good's insurance if you can't get to a doctor? So you got to have access to care. That's my second one. And then my third one is cover everybody. I think we could cover everybody. So here's how I would lower cost. I would connect the system together. Today, the government sets reimbursements for Medicare. Average hospital loses 9.9%. So let's call it 10% on Medicare. So they slightly underpay hospitals. Average employer plan pays 241% of what Medicare pays for the exact same services.
It's incredible spread, isn't it? It's just...
So it gets worse every year. So we have this huge discrimination, a hidden tax. That needs to go away. So we need to link what everybody pays to what Medicare pays. But here's the problem. If everybody paid what Medicare paid, insurance costs would be a whole lot less. You know what happens to your hospital?
Yeah, this.
Your doctor. It's gone. So we've got to think about how do we reduce the dollars for everybody without putting the hospitals, the doctors, the other things out of business. So it is a very connected. How do we do that without taking everybody out? What nobody thought about in Senator Sanders' Medicare for All program was the fact that the doctors and hospitals, the way we have it today, they couldn't afford to stay in business under that plan. yes, everybody would have insurance, but if 30 to 40% of the hospitals in this country shut down, what are we going to do? And that if you just overnight said that's it, that's the reality, because there's not enough money in that to pay for the system we have. So we have to draw that down over time, but not in such a way that hospitals are there. Now, does that mean hospitals are going to make less money? Yep, they are. But you got to let it adjust. So that's how I would lower cost, and that's how I would protect access. I would be very intentional. Covering everybody for me is tough love. It means that if you're eligible for a government plan that's free and you don't take it, you don't get any care. And I'm sorry, but that's it. In Obamacare, so that's about a third of the population. Another third is eligible for an Obamacare subsidy, but they don't take it. Taxpayers pay 87% of the premium on average in Obamacare. So you're paying 13 cents. Somebody else is paying 87 cents of that premium. Your 13 cents is less than your cell phone bill. It's less than $100 a month. If you're eligible for that, you have to take it. If you don't take it, okay, but your penalty is more than the cost of premium. So only an idiot wouldn't do it. And so again, that's Texas tough love of how we deal with that. And then you get to the other populations. Now we're down to about 20% of the total uninsured population by the time you do all that. 2 moves and you've taken care of most of it. And then we figure out how to deal with that, the rest of the population. Some of it is expanding Medicaid in states that didn't expand.
Yeah.
Some of it is the wealthy that say, I just don't want to buy insurance. Well, then, okay, don't buy insurance. Your estate's going to have to pay back the government for care. I mean, you can figure those things out.
But one of the things which I got, and I remember when I used to do some of these groups, we used to call them risk huddles because the pools kept getting smaller and smaller. So we agree on this. Really, to get true insurance is spreading the risk. So it's everyone into the pool. Otherwise, you're out. Would that make sense?
It is.
Because when you because that's, I don't know, and that's, I think really by getting everyone in, then you're gonna have true insurance. You're gonna be getting truly the benefits of large numbers, which we already have, and life insurance and car insurance and all the other stuff. Okay, but for some reason, healthcare people just are goofy. Now,
and when I talk about this connection between what Medicare pays and what everybody else pays, I have being in Texas, I get a lot of funny looks on that one. And so people say, well, it sounds like a form of price fixing. And my question back is, but what if the price needed to be fixed? What if it was so broken that we had to fix it because it makes no sense? Does it make sense for a person in one room be paying one price and the person in the room next to him be paying 5 times that price just because of who they think is going to pay the bill? I go, and that's the level of wrongdoing that's happening with the pricing. And I wish we could have a free market system that would just solve it. Unfortunately, after 30 years of trying everything I can to try to fix it, I think it is a public-private solution. It's taken the best and the right of public systems, the best and the right of the private systems, and proactively putting them together. Short of that, I think we end up in a total government takeover of all healthcare, and I just don't think that that's what America wants. It sounds good, but
and if you think healthcare is expensive now, wait until the government takes it over. It's like.
Yeah, well, the example that I've used is, okay, so let's look at the COVID testing. And then people go, oh, these long lines, and and it was a mess, and you couldn't get the test results back. Well, who was trying to run all that? The government. Well, they're not great at running things like that. I've not had a great experience in customer service with the Internal Revenue Service. They're not in that, but they are. The government does have a valuable role in certain things in healthcare, but the private sector also has a valuable role in customer service, in innovative design, in those kinds. So you take the pooling and the pricing, and you figure out how each stakeholder does the right thing, and you know what? We can navigate this thing and get it to work. And we don't put millions of Americans out of work, and we stop bankrupting millions of families. We can do this.
Yeah, and well, in the Wall Street financial engineering, I don't know if you see it in your end. I see it because I've been researching this to death, and it's pretty frightening. How they get involved in the hospital systems and nursing homes and all this stuff, and now with they can't own physician practices, but they can own the management companies, and they're dying right now, but they're squeezing the bejesus out of some of these companies. I'm a free market guy. Okay, I love Austrian economics. I'm a free market guy. Okay, but what you laid out about prescription drugs in this country, there is no free market, is there, Dan? I mean, what are we? 4% of the world's population. We spend like 42%.
Yes.
So. And what was the one drug you mentioned? One of the drugs is you can get like for 51 cents in India, or is like $700. It was one of the drugs in there.
Yeah, there's a drug that that has been around for over 65 years now, and it's used if you get a certain parasite. And it's on the World Health Organization's list of essential medicines. So it's available in every country of the world. Because if you get this parasite, the parasite will kill you. If you take this drug, it kills the parasite, and after a 90-day, you take it for 90 days, you're fine, the parasite's dead, and you go on the rest of your life, no complications. But if you don't take it, it kills you. And so it's available everywhere in the world. There hasn't been any R&D in my entire lifetime because it's been around before that. And so one company, Turing Pharmaceutical, bought the rights to this drug in the United States.
Was that owned by the guy?
Yes. And so Turing buys the rights to this drug and raises the cost for a 90-day supply to about $70,000. And there's nothing that says they couldn't do that. No one else manufactured it. They had the single rights in the United States. And so they just said, hey, it's $70,000. If you want it, here it is. If you don't want it, not our problem. Oh, and by the way, you can't import drugs from another country. That's illegal. And so they had the perfect free enterprise program initially, but you look at it and no one would say that's ethical. I mean, yes, it's legal, but is it ethical? And we would all say, that doesn't feel right. So I went online and tried to find, so I went, and my daughter had gone to a trip to India. So I'm going to guess this parasite's prevalent in India. I'll just see if I could buy it in India. So there's an online pharmacy in India. They had, I think it was 19 different versions that you could buy. And the most prevalent one that they sold was less than $5 for a full 90-day supply.
$5. And what are we charging?
$70,000 in the United States, less than $5 in India for the exact same drug. And I think if the American people understood that, they would say, okay, I'm a free enterprise person, but that is stupid. It just that you can't do that. And so that's really why the Trump administration is trying to open up borders for drug reimportation. They're looking at most favored nation pricing status, that we're going to look at what other countries pay, and that may be some formula of that is what we pay, because the American people are getting discriminated against in pricing. And we really need to wrestle honestly with that issue and figure out what can we afford? Can we afford to spend, or to fund 42% of the world's pharmaceutical budget for only 4% of the people? And most people would look at it and go, I'm not sure we can afford that.
We can't. Now, Jen, this has been an awesome conversation. How can people connect with you, or be of get your book. Is it on Amazon now?
It's Amazon and Barnes and Noble have it. Voter's Guide to Healthcare is the name of it, and on the web, Voter's Guide to Healthcare, and they can watch for things that we're putting out. We've kind of slowed down a little bit in terms of COVID to try to let that play out, and are now, I think as the Biden campaign is now the Biden-Harris campaign. I think we'll start to get some of these issues back to the forefront on really where both campaigns are going.
Yeah, it'd be nice to see some compromise. I mean, America. It's funny. If you're in business, we know we have to compromise with people, and everyone wants something. But it's such a dogfight now, and it's just and the whole thing. People, there should be good care for everybody. If we're scientific about it. Right. And I highly recommend the book. It was good. I mean, what shocked me when I started looking at it, holy moly, what the healthcare costs are, and then the Humira drug, and it's just, well, I said there is no free markets in prescription drugs, and we're really kind of protecting big pharma, and it's kind of like big interest. So, how else can how can people get in touch with you about speaking on this or doing other interviews like this?
Yeah, my email address is dbishop@holmesmurphy.com, and people can feel free to email me, and happy to talk to any groups or anyone really about the subject. You can call me a health insurance nerd. I accept that, but I am passionate about trying to positively influence this dialogue. We can solve these problems. It can be affordable. Everyone can be covered, but we can't do that if we think the government is the only problem or the government is the only answer. We will never solve the problem. So it is truly looking at what assets do we have, how do we align them appropriately, and how do we create a system that has rights that are paired with responsibilities. Got to have both.
Yeah.
He counted on America to be passive. He counted wrong.